Okay, Bismillahirrahmanirrahim. This is our part 3 of the upper limb Viva question. The muscle attached on the mid shaft of the humerus is deltoid is inserted at the deltoid tuberosity, and calyx originates from the lower half of the anterior humerus. A clinical importance is radial nerve passes from the radial roof, and if there is a mid shaft fracture, the radial nerve is going to damage, and there will be a wrist drop. Extensors will get damaged or injured. One liner for the Viva is brachialis originates from the anterior mid shaft, and deltoid inserts at the deltoid tuberosity. It can be asked to you in your exam, and radial nerve runs in the radial groove. Now I have made another question, so I added few more questions. That's why I am making another part 3. That is, superficial palmar arch is formed by the ulnar artery, usually completed by the superficial branch of the radial artery. It lies just beneath to the just deep to the palmar aponeurosis, superficial to the flexor tendons. Its branches are common palmar digital arteries divided into proper palmar digital arteries to fingers, palmaris brevis branch. Occasionally, clinical importance is it can be used in Allen's test to check the arterial supply of the blood. What is a deep palmar arch? Deep palmar arch is mainly by the radial artery completed by the deep branch of the ulnar artery. It lies deep to the flexor tendon on the base of the metacarpals in front of the metacarpal bones. Its branches are palmar metacarpal arteries anastomosed with the common palmar digital artery superficial arch. It gives principus pollis artery and radialis indicis artery for thumb and lateral index finger. Clinical importance is it protects the hand from ischemia if one artery is occluded. Importance in surgical flaps. Now one liner for the Viva. Superficial palmar arch is formed by the ulnar mainly and gives common and proper palmar digital arteries. Deep arch is formed by the radial, gives palmar metacarpal princeps pollicis and radialis indicis arteries. Which muscles are involved in holding a pan? Muscles involved in holding in the pan are the intrinsic muscles, thenar muscles, and these muscles are the opponens pollicis, abductor pollicis brevis, flexor pollicis brevis. It controls the thumb movements. Hypothenar movements stabilizes the little finger, less important in the pen holding. Okay, lumbricals, first and second hand, flex the metacarpophalangeal joints and extend the interphalangeal joints of the fingers. Introshi assist in the fine movements and the grip. Its median nerves supply the thenar muscles in first and second lumbricals, flexion at the metacarpal and thumb opposition. Ulnar nerve supply the third and fourth lumbricals and introshi and adductor pollicis and fine control and stabilization. Injury to the median nerves leads to inability to oppose thumb. Ape hand deformity affects the pen holding. Injury to the ulnar nerve, weak precision grip affects wrist writing stability. Now I have made again repeated this question. Arm abduction 0 to 15 degree abduction is performed by supraspinatus, 15 to 90 degree by deltoid, and above 90 degree by trapezius and serratus anterior. Shoulder joint ligaments are glenohumeral ligament, coracohumeral ligament, coracoacromial ligament, transverse humeral ligament, and glenoid labrum. Deepens the glenoid cavity, and bicep brachii tendon stabilizes the shoulder joint anteriorly. What are the elbow joint ligaments? Medial collateral ligament, lateral collateral ligament, annular ligament, and quadrate ligament. These are the, and you can read the functions of these muscle. Prevents varus stress, encircles, but that is not that there. These points are not very important. You just at least you should know the name of the ligaments of the shoulder joint, elbow joint, or knee joint in the lower limb. I am going to tell you in that lower limb Viva video. Shoulder joint ligaments are glenohumeral, coracoacromial, transverse humeral ligament plus glenoid labrum. Elbow joint is ulnar collateral, radial collateral, annular ligament, and quadrate ligament. Thenar muscles are these are the intrinsic muscles of the hand located at the base of the thumb. Thenar eminence. Thenar is on the thumb side. That's why its name is the name indicates thenar. And they are mainly responsible for the fine movement of the muscles, and the muscles included in it are the LOAF rule, median nerve supply, lateral to lumbricals, not in the thenar eminence, but same innervation rule. Off is thenar eminence include three muscles: off, opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. And its function is allow opposition of the thumb touching tip of the thumb to the little finger, enable precise grip, pinching, writing, and buttoning clothes. Median nerve injury, carpal tunnel syndrome causes thenar muscle wasting, loss of thumb opposition, ape hand deformity. Hypothenar muscles, these are the intrinsic muscles at the base of the little finger. Hypothenar eminence, they control fine movements of the little finger. The muscles are abductor digiti minimi, flexor digiti minimi brevis, opponens digiti minimi, plus palmaris brevis overlying superficial. Its importance is move the little finger in abduction, flexion, and opposition. It helps in the grasping large objects by cupping the palm, supplied by the ulnar nerve. Thenar muscle precision, grip, writing, delicate hand function, hypothenar power grip, widening and cupping palm. Median nerve injury leads to the loss of thumb opposition. Ulnar nerve injury, hypothenar wasting, weak hand grip. Palmar aponeurosis, now I am telling you about it. Palmar aponeurosis is basically a thick triangular fibrous sheet in the center of the palm, continuous with the tendon of the palmaris longus and flexor retinaculum. Its shape is triangular. That's I have already told you, attached to the flexor retinaculum and the tendon of palmaris longus. Its base divided into 4 slips, each going to each finger at the level of the metacarpophalangeal joint. Each slip divided into 2 bands, passes around the flexor tendons. The fibrous flexor sheet and deep transverse metacarpal ligament. Superficial to superficial palmar fascia, palmaris brevis, superficial vessels and nerves deep to the longer flexor tendon, lumbricals and superficial palmar arch. Its function and importance is it protects the underlying nerve vessels, tendons in the palm. It provides firm attachment for skin, improves the grip, maintains palmar concavity for cupping the hand. It helps anchor palmaris longus tendon. Dupuytren's contracture is progressive fibrosis and thickening of the palmar aponeurosis. Flexion deformity of fingers, especially ring and little finger, acts as a barrier localizing infections of the palm. Superficial palmar arch mainly by the ulnar artery. Location is deep to the palmar aponeurosis and palmar brevis. Branches 3 common palmar digital arteries, each divided into 2 palmar digital arteries. One proper palmar digital artery. Clinical importance is supplies fingers mainly. Deep palmar arch mainly by the radial artery, and completed on the medial side by the deep branch of the ulnar artery. Its location lies just about 1 centimeter proximal near to the wrist compared to the superficial palmar arch. Branches are palmar metacarpal arteries, perforating branches, recurrent branch. Clinical importance is supply the metacarpal bones and deep muscles of the palm. It provides anastomosis with superficial palmar arch for collateral circulation. And phases of abduction of arm, which I have already told you. I think we have discussed this. 0 to 5 to 15 degree supraspinatus, 15 to 90 degree deltoid, above 90 degree trapezius and serratus anterior. Injury to supraspinatus, difficulty in starting abduction. Injury to axillary nerve, weak abduction beyond 15 degree. Injury to long thoracic nerve leads to serratus anterior, winging of scapula. That is a common ask question. What is anatomical position? The anatomical position is a standard reference posture used in anatomy to describe the location and relation, in which you have to tell the facilitator that the person must be in upright position, head and eyes facing forward, upper limb at the sides of the body, palm facing forward, supinated, finger extended, feet together and toes pointing forward. There is also something written about the thumb, but it is not mentioned here. You can see it in the KLM. Its importance is provides a uniform starting point for describing the anatomy. All anatomical terms like medial, lateral, and anterior border can be defined related to this position. It ensures clarity when describing the movement plane and relation of the other structure. Where does the brachial plexus emerge from? Ventral rami of the C5 through T1 spinal nerves. Name the branches arising from the posterior cord of the brachial plexus, axillary, thoracodorsal, upper subscapular, lower subscapular, and radial nerve. What are the boundaries of the axilla? Medial wall is the serratus anterior and the first 4 ribs. Humerus and coracobrachialis and the short head of the biceps form the lateral wall. Pectoralis major and minor muscles make up the anterior wall. Clavicle, scapula and first rib comprise the superior wall. Posterior wall is the teres major, subscapularis and latissimus dorsi muscle. What are the clinical signs of an upper arch brachial plexus? Routine paralysis, waiter tip position, arms, waiter tip position, adducted and internally rotated arm, extended forearm and flexed face, flexed wrist, like a waiter is asking a tip in a hidden manner. During a physical examination, a patient is unable to abduct his arm beyond 15 degree. It means that deltoid and axillary nerve is damaged. What are the clinical features? Okay, what are the clinical features of the radial nerve injury? Wrist drop, inability to extend the fingers and loss of sensation on the dorsum of the hand. What are the common site of the ulnar nerve entrapment? Cubital tunnel or Guyon's canal, wrist and it is present at the wrist. Which muscle stabilizes the shoulder joint? Rotator cuff muscle. Which muscles are responsible for flexion of the wrist? Flexor carpi radialis, flexor carpi ulnaris and palmaris longa. A patient is unable to flex the distal phalanx of the index and middle finger. Which nerve is most likely damaged and which muscles are get affected? Median nerve, flexor digitorum profundus, lateral half. Name the major artery supplying the upper limb: subclavian artery, axillary artery, brachial artery, radial artery and ulnar artery. Which artery supplies the deep palmar arch? Radial artery. How does a rupture of the bicep tendon present clinically? Papaya deformity. That's it. Please do not forget to subscribe my channel for more such important Viva videos and other important related medical related videos.